Welcome to Real Health Chat, our stories of health, justice, and change. I'm Julie Hard, Director for Global and Community Partnership in York's Faculty of Health, and this is where we sit down for authentic conversations with the researchers, educators, students, and community partners who are building healthier worlds right here at York University and beyond. No lectures, no jargon, just real people sharing the work that's creating upstream change in our communities. Let's chat. Today, I'm joined by Dr. Benedict Weobong, a professor at York's School of Global Health. Dr. Weobong is a global mental health epidemiologist whose work spans from developing psychological treatments for young people in Ghana to training the next generation of mental health researchers across Africa and here at York University. His research focuses on scaling up evidence-based mental health interventions in low-resource settings through innovative approaches like task sharing. And this winter, he's launching a new global mental health course right here at York that explores the foundations, cultural dimensions, and human rights approaches to mental health globally. Dr. Weobong, welcome.
Thank you so much, Julie.
So let me get started by saying you've dedicated your career to global mental health, working across Ghana. And I've just learned you were in India, in the UK, yes. And now you're here at York with us. When you look at the current state of global mental health, what's, in your estimation, the biggest challenge that we're facing where people might not fully understand?
Oh, that's a good question, and thank you for having me here. One of the key things that we don't really know, that the story is not really told well, is the issue of access to mental health services. It's a huge chasm that we are dealing with here. I mean, just to put things in perspective, we're thinking about more than 1 billion people on this earth are living with a mental health condition. About 8 out of 10 of them are found in low and middle income country settings. Now, most of these folks do not get access to treatment. Now, this is further compounded by issues of disasters and catastrophes, and that is really where the issue is.
So if you're able to, so you talk about the global mental health chasm, and it's becoming more pronounced with catastrophe and disaster. What does that actually mean for people or someone who is experiencing a mental health crisis in a low resource setting versus here in Canada?
I mentioned the fact that most people do not get treatment. So this concept of the treatment gap that we talk about a lot in global mental health. For now, we are dealing with a huge problem. And would you want to guess what the treatment gap would be in low and middle income countries compared to Canada?
You know what? I don't even think I want to guess because I feel like it would be enormous.
Absolutely, it is. We're talking about 90% of folks who have a mental health condition and diagnosed mental health condition in low and middle income countries do not get access to treatment. Now, compare that to 50% of that same story in Canada. So that's how.
Are people even getting diagnosed? Is a question.
That is a real thing, and some of the work I did in Ghana actually unearthed that the detection rate is almost 0% in primary healthcare.
Wow.
And that already tells you the need that we are really grappling with. So yeah, that is really the big thing that we are dealing with that.
I'm just going to take a little bit of a sidestep, but on this topic, you have introduced to your students a concept from the late Dr. Paul Farmer. And I think this kind of speaks to this gap that you're talking about and why people are not getting treatment. Yeah. But I want to hear from you about a concept called socialization of scarcity. This is the idea that we've been socialized to accept that some people simply live without basic resources and healthcare based on where they're born, their skin color, their geography, a number of factors. And that's a very powerful and uncomfortable idea that we accept, and we seem to be socialized to accept this scarcity. Why do you think that we've accepted this as normal?
Actually, what you've just described, Julie, it ticks all the boxes of what a social determinant is. I think it's an issue of people probably not understanding what it is that we are dealing with here. And yes, I don't agree with that. It makes me very uncomfortable to even think about the fact that we are socialized to accept our situations, and the fact that where we are born determines our access to healthcare services and our quality of life. Now, for me, I think it's stifling. It's a very stifling concept. What it means is that it takes agency out of us. Now, persons with mental health conditions, you would be amazed that they do have what it takes to actually thrive. But this thinking limits that ability, and Giddens made it very, very clearly in his writings. And so for me, I think it is a very, very, very uncomfortable concept, which I think that we have ways of working around that. In global mental health, for instance, one of the ways we are doing to tackle that is through, solutions like task shifting, integrating mental health services in primary health care. Now, I must be quick to say that is not a workaround to deal with this concept. It is really actually pointing to challenging the system that creates that. And our way of challenging that system is to show that it is possible to do this.
Can you give us an example?
Well, I guess there are quite a number, and very, very useful in terms of some of the work that we've already done in my work in India, but also in Ghana. And Global Mental Health has been able to create very, very good data that shows the effectiveness or the efficiency of lay personnel, people who do not have the background training in mental health, being taken and trained in offering basic psychological treatments to people. And we have found that it actually works as equal as, if you like, the specialist.
So this is an example of task shift.
Yes.
Okay. I'm glad you actually provide that illustration and visualize it. In your own research, you've been across multiple continents, from Ghana to London to India, and now you're here, working on everything from perinatal depression to adolescent mental health interventions in Ghana.
Yeah.
What actually draws you to this kind of work, and what have communities taught you about mental health that you wouldn't have learned in the classroom?
Now, when I started my work in the early 2000s, it struck me when we started visiting the field to recognize how, or it struck me when I found out that people do not know that mental health conditions are treatable. That was the first thing that hit me. Then when I started doing my own PhD, as you were rightly mentioning, perinatal depression, in one of my field visits when I was interviewing this mother with a PhD name, the mother had just given birth, so postnatal, right? And the baby was like, obviously in distress, crying. But the mama didn't really react, didn't want to go and help the baby. But when I reflected on it, I realized because I was holding the measure in front of me, it was very clear. This woman was going through serious morbid unhappiness. Now, that really tells you what really it is. And the third reason why I do this is very recently, just before I moved here, some of my work in integrating mental health services in primary health care, we came across a very sad story. The story of Ayimpoka.
Okay, can you say it once more?
Ayimpoka, yeah.
Okay.
It's the name of a lady that we encountered. And you know what? As I thought about it a bit more, it just resonated with me how Arthur Kleinman in Harvard actually characterized what we are doing to persons like this as the failure of humanity. Ayimpoka has a mental, neurological, and substance use issue. So we in Global Mental Health would like to put the three together. So she has a neurological cause epilepsy.
Mm-hmm.
Now, because of her condition, obviously, you can take medications and it can calm down the number of seizures you get and all that. But there was a truncation in her access to treatments for a while. But she couldn't get treatments. She couldn't get her tablets. Now, so she had a seizure. She had a seizure while she was cooking. And obviously, she fell. And she had a very, very bad burn and had to get her hand amputated. Now, This is just This only tells you what one thing, just one slip of not getting this lady her medications, what they can do. Now, she's now physically disabled. And on top of that, she has a mental health condition. And you can think about what that means. That combination is not great. So these are the things that keep me awake in the night. And I keep thinking, how do we make things better for people? How do we get mental health services to people like this?
I'm going to actually dive into something based on what you've just said that might be considered a bit provocative, and something that I've heard that you're going to be exploring in this new course. So the late Dr. Paul Farmer also coined the term weapons of mass salvation to describe medical tools like vaccines, medicines, and treatments that have the power to save millions, contrasted obviously with weapons of mass destruction.
Yes.
And he argued that we have these life-saving resources but lack political will to distribute them equitably. So you're bringing this concept to your global mental health course. Can you give us a little bit of a teaser of what that discussion and how this framework applies to mental health?
The thing that we are thinking and putting so much money into the best defense systems and best weapons. Here someone is on his way to a certain country to ask for weapons, long-range weapons and all that. Now, there's so much talk about security in terms of being strong and fighting and have the best weapons. And we're losing sight of it. And that's why Farmer, I think he just wanted to challenge the conscience of the world to the fact that we need to be thinking more about these weapons that help and make people better, that inflict more pain and suffering to people. And we know that wars do that. So in my course, I'm going to get students to think about it a bit more, about what kind of weapons of salvation could they think about that they could begin to form so we can change that narrative going forward. That's really the thinking.
I really love the positivity, but also, you've got the contrast of weapon with salvation.
Exactly.
It's really powerful.
Yes. Yeah.
So when you look at global mental health, some might argue mental health challenges are just too large to tackle and there's just not enough resources. So how do you respond to that position? Is this really about scarcity or about priority?
I think it's both. I would say it's both. Both in the sense that, yes, it is true that we have scarcity of resources in terms of human resources. We don't have so many people who provide mental health services. In my country, in Ghana, we have less than one psychiatrist, 200,000 of a given population. But I also want to challenge this a bit more, that there's also scarcity in knowledge. I think it is scarcity in knowledge that then feeds into the issue of low prioritization of mental health in the global health agenda. Because if you do know what investing in mental health would do to the global economy, then you wouldn't even think 1 second why you should prioritize mental health. We did some work, or colleagues in Ghana did some work in Ghana. And we did find out that for a 10-year period, if you invest $1 in treating depression, you get a return on investment about $7. Now, there are lots of examples like that. This is just one. All right. And so I think it's really because, while we don't have the resources, human resources, so we have to think about ways around them, but it's also that people do not really understand why we should prioritize mental health conditions.
So you need to speak to them in a language they understand.
Or show them the clear examples, with concrete examples of what really this can do. Well, give us a space and we'll do that.
And this is where our students come in.
Yes.
Yes. So you're launching your new global mental health course this winter. What do you want students who take the course to walk away with understanding principally? Like if they come out of your course with one thing, and maybe this is we haven't launched the course yet. Maybe this is an unfair question. But how can they become those agents of change in addressing mental health inequities? What are the things that you would like them to come out of the course with?
Well, I would like them to come out with competencies that allow them to be strong voices in their communities. And so the course will do that. The course is designed to help them provide the practical tools on thinking of solutions. One of the things that I will put to them is, what is that one thing we can do to change the narrative? That's what I'll be asking them throughout the course. And they need to think about that. And I'll be helping them, working with them, providing them the tools. And one of the things that we're going to do is to give them a lot of exposure into what really happens in communities. So our experiential thing. And hopefully through that, when they work with communities, they can begin to know, identify problems, and then come up with solutions collaboratively. And also one of the things that I'd like that course to really do is to help them to know how to take care of their own mental health and people around them. So that's the other pillar of this course. That by the time they are through, they would know how to deal with the basic situations we deal with, like stress. How do we even manage your own stress so to increase your productivity? So I think that there's a lot for them to gain when they do take this course.
This sounds like an amazing course. And I love the fact that you just paid a small homage to the fact that there is some experiential education, but that's my bread and butter here. So maybe you could just elaborate a little bit on the experiential education side and say whether the student comes out working here in Toronto locally, or if they plan to go globally, what kind of experience do you think that they will get, or that you're envisioning in the course?
They're going to go into a certain culture when we send them off to these communities. They have to understand that. They have to understand that it's not everything that they come with is what should be respected or should be used. They have to be able to know how to negotiate.
And they'll have the opportunity to do that.
And they will have the opportunity to do that in the course because they will be thrown into it. And so hopefully when they go out, and they can go out to places like NGOs and work with, with lots of NGOs are looking for folks with mental health backgrounds now in thinking through basic interventions, and with the course, it will give them that, to give them those skills to be able to, because one of the things they're going to do is to design a mental health promotion program or project. And that already puts them on that. Because I've always said, and it's interesting, in my last class, one of what we were discussing social determinants, and we're thinking about the two hypotheses that help us understand the mechanisms of social determinants, social causation and social drift. And one of the students said to me that, I was pushing them to think about something, and obviously they weren't ready to. It was a great class. And then they told me that, well, I think it should really be social causation, because after all, you failed. You've been doing social drift, which is really treating persons. Essentially, what we are saying is that if you treat persons with mental health conditions, then you prevent them from drifting into poor circumstances, which then has a ripple effect or visual. Excellent. And so what we've been doing in till date is just the treating thing, because we have evidence that works. Social causation tells us that if you address the surrounding issues, the structural factors and upstream issues around what we should do for individuals, provide for their needs, address poverty, and all those factors, they are likely to prevent persons from, isn't it, right? Development of conditions. That's what social causation says. And so she challenged me and said, well, I think we've been doing it wrong anyway. So we've been doing social drift all the time, all these years. So we should really begin to think about preventing. And that's why for this course, I really want to begin to get the students to think about preventive approaches to mental health and not just the treatment, because we've done it for quite a while and we're still not shifting the gap.
Got it. Fantastic. This sounds really interesting. I'm going to do a little bit of a gear shift, and thank you for this important conversation.
Okay.
We are getting close to the end of our time, but before we wrap up, I want to ask you a few rapid fire questions.
Oh, no.
So these you're not prepared
I'm horrible for that.
Yeah, but we're going to ask you a few questions, just 1 or 2 word responses. First thing that comes to mind. Can I pass
also?
Well, you could pass, but it's just you and I in the room, so I'll pass it right back to you. So tell me, what's one thing about global mental health that would surprise most people?
That is not really well known.
And if you could change one policy tomorrow to improve global mental health access, what would it be?
Let's make use of lay counselors. Essentially, let's train more people to provide services.
Do you know of any mental health innovation from a low resource setting that high-income countries should learn from?
Oh, of course, the friendship bench comes right to my mind.
Friendship bench?
Friendship bench.
friendship
The
bench.
friendship bench.
Friendship bench.
Yes. You heard of the friendship bench in Zimbabwe?
1 minute to explain a friendship bench.
Oh, it is a community-based mental health intervention, which really interfaces, essentially bringing mental health to the community, to the steps of the community. And it's really like a bench. And you train lay counselors again.
And you just sit on the bench.
And people come and talk about the mental health conditions all day and just ventilate. And it's amazing. In fact, it's happening. It's happening right now. There's reverse engineering happening now.
I really appreciate it. I think I'm going to stop the rapid fire because you answered that so nicely. So this is a wrap on this episode of Real Health Chats with Dr. Weobong. Thank you for this powerful conversation and the work that you're doing to challenge how we think about mental health equity globally. How can students learn more about your global mental health course starting this winter?
Well, the School of Global Health website, the Global Mental Health stream, the sites there, we have lots of information about that over there. We also did some info sessions, and we have a recording of it. So try to see how we can make that available and accessible to people. But yes, please just also say, walk up to me. Just walk up to me if you see me anywhere, campus or in class. Walk up to me, and if you want to have a conversation about it, I'm very happy to always do that.
Fantastic.
Real Health Chats are produced right here from York University's Faculty of Health in the Real Health Studio. For everyone listening, if today's conversation resonated with you, we'd love to hear about it. And if you're working on something that's building healthier communities, we'd love to hear about that too. Send us an email at eehealth@yorku.ca. Until next time, this has been Julie Hard, and we'll chat soon.